I'm Dr. Justin Moon. I'm a neurologist and the director of the Denver Neurological Clinic. I've been in independent practice for 15 years.
And I'm Dr. John Bertelson, a behavioral neurologist. I see patients at the University of Texas in Austin, a clinic at Texas Tech, and I have a private practice also here in Austin.
We're going to share with each other and our audience how we walk through patients and their loved ones through the journey with LEQEMBI.
And we'll be sharing insights from our own practices. I'm looking forward to learning from each other.
I am as well.
Summary of important safety information. Indication. LEQEMBI is indicated for the treatment of Alzheimer's disease. Treatment with LEQEMBI should be initiated in patients with mild cognitive impairment or mild dementia stage of disease, the population in which treatment was initiated in clinical trials. Summary of most serious and most common risks associated with LEQEMBI. Boxed warning: amyloid-related imaging abnormalities, ARIA. Contraindication: contraindicated in patients with serious hypersensitivity to lecanemab-irmb or to any of the excipients. Reactions have included angioedema and anaphylaxis. Warnings and precautions: ARIA, hypersensitivity reactions, infusion-related reactions. Most common adverse reactions: infusion-related reactions, ARIA-H, ARIA-E, headache, superficial siderosis of central nervous system, rash, and nausea, vomiting. Injection site reactions have occurred with LEQEMBI iClick. Please see full important safety information and accompanying full U.S. prescribing information, including boxed warning.
As we think about Alzheimer's disease, or AD, do we think about it as a static disease? No. We think about it as an active process that is continuously happening. Therefore, it makes sense that if amyloid is continuously accumulating, we may need ongoing treatments to slow the progression of disease. To me, this suggests that identifying and treating patients at earlier stages of the disease is a critical aspect of Alzheimer's disease management.
Absolutely. It's also important to identify AD in the MCI or mild dementia stages so we can help provide answers for our patients and their families. They have so many questions, such as, is this normal aging or is this a disease? There can be peace of mind just knowing what is going on. Identifying patients early, especially in the MCI stage when they're capable of making meaningful decisions related to their health, is particularly important. It empowers the patient to help guide decisions that will affect the rest of their life. It is also reassuring to the family knowing they don't have to make future decisions entirely on their own.
When we make clinical diagnosis of MCI or mild dementia, we're saying that the patient has crossed a certain threshold of cognitive or functional decline. But the biological processes of Alzheimer's disease begins years, even decades before the patient ever walks through the door. It is imperative to identify these patients as early as possible. Now that we do have a therapy that can slow down disease progression, I think it's imperative that we change our paradigm and start diagnosing this disease early. When I do an initial evaluation of patients and families who may have heard the news of LEQEMBI approval, and I have to tell them that they have progressed to a moderate to severe stage of AD and are no longer indicated for this treatment option, seeing that disappointment shows you even more how vital it is that we get this process started early. Dr. Bertelson, what are some of the challenges that you hear from primary care regarding the timely care for their patients with cognitive disorders?
There are unfortunately many challenges to identifying these patients in a timely manner. Many doctors don't have the time in an appointment to explore all the possible problems that their patients might be experiencing, in particular problems with memory, which many patients don't notice or feel apprehensive to report. Some doctors tell me they don't explore problems with memory loss because, as we mentioned earlier, there has been a lack of treatment advances to address cognition and function or early AD over the past 2 decades. Finally, there is a shortage of specialists in memory disorders such as ourselves, so some doctors have even given up on referring their patients.
I often hear the same things. So, what's your advice?
First, have a low index of suspicion for cognitive problems. Notice if they repeat themselves, are unaware of their medications or recent medical problems, miss appointments, or demonstrate other red flags for having a cognitive disorder. When time is tight, consider scheduling an appointment specifically to explore cognition. Definitely invite the spouse or other family member to attend the appointment or ask to talk to them over the phone to determine if there are key symptoms the patient doesn't report. Since many patients with AD don't remember if they're having a problem with cognition, sometimes a family or close friends are the only ones able to report these symptoms.
This is why it's important for primary care clinicians to pay heed to their patients and their families, especially in those in early stages. If a patient says, "Look, I'm having some difficulty with thinking," or if a family member expresses concern, I think it's reasonable to have an initial evaluation. That initial evaluation should take place in the primary care office with their own bedside evaluation. And if that is showing signs of an abnormality, then it is completely reasonable that the patient be referred for further testing. When a patient is referred to us from primary care, we can start fresh with our own workup or take any bit of information that has been relayed to us and utilize that.
I agree. I would encourage primary care to initiate whatever workup they're comfortable with. At the very least, I would like the referral to include a medication list, routine blood tests, and the results of some form of cognitive screen. The results of a brain MRI are also appreciated. Knowing this information helps the specialist prioritize the urgency of the visit and determine if it's even appropriate for them in the first place. In each of my clinics, we get a history from the patient and a member of the family, if available. While I like the opportunity to obtain information privately from the family, that is sometimes difficult to accomplish. So you do your examination, which not only is checking balance, strength, reflexes, but also includes some sort of cognitive battery. And there are several well-known tools to choose from, but they should be adequately sensitive to MCI. You should also need to know their education and occupational history. For example, if they didn't finish junior high or high school, you might interpret their cognitive screen differently than for someone who's a college professor. If one hasn't been done already, I suspect most neurologists would order an MRI. While a head CT is adequate for some purposes, brain MRI is more sensitive for vascular pathologies and many white matter diseases. Certainly if the patient may be a candidate for a medication such as LEQEMBI, an MRI should be a component of the initial workup up front.
In our clinic, we do an initial MRI and basic labs, as well as an EEG and bedside memory evaluation. Upon their return visit, they would have the memory test first thing in the morning to get an accurate memory evaluation. Then we would assess the patient and try to determine whether this pattern seems consistent with a progressive neurodegenerative process. I think the key is for clinicians to try to evaluate their patients with their standard measuring tools and then continuously reassess those measuring tools over time as new ones become available. Then, in my clinic, we would consider a next tier evaluation with FDG PET and independent evaluation by neuropsychology. However, now with advancements in testing, we are using blood-based biomarkers to facilitate identification. Confirming amyloid pathology is the next step for making the diagnosis of Alzheimer's disease. Laying the groundwork for this diagnosis starts with the first visit. We tell them we're going to do a memory evaluation. And I always tell them, hey, it's not a bad idea at this stage in life to have a baseline evaluation. Then you at least know where you are. Maybe it comes back normal and we don't have to worry about it. If it's abnormal, we might do additional testing. Then I say, there are newer therapies available, so we may want to consider those therapies. I lay that out at the beginning, not with too much detail, but with a broad stroke. At the second visit, we get more specific. We say, these are the next tests to see if we have the pathology that the newer therapies target. And then we talk a little bit more about the medication. When we get to the confirmatory tests for amyloid beta, then we really talk heavily about therapy and potential treatment options available. What about you, Dr. Bertelson?
The first visit is when I see them, I meet them. I do my history, I gather my information. Second visit, I go over tests and hopefully will give as much of a diagnosis as I can give. Generally, in the second visit, I can say, okay, I suspect this might be Alzheimer's disease. There are treatments that have been available for 20 years that we should consider, but there's also a new agent that I'm particularly excited about. Depending on their response, we might then proceed with a spinal tap or amyloid PET to look for amyloid pathology. I will also order ApoE testing if this hasn't already been done. Depending on what has been decided at the last appointment, visit 3 is about confirming eligibility for LEQEMBI. This consists of reviewing amyloid tests and ApoE results. We also ensure there are no new relevant medications or medical problems.
When considering appropriate patients for the treatment with LEQEMBI, the first questions we ask are, would the patient be interested in such a therapy? Are they at the earliest stages of disease? Are there any significant factors that might exclude them? Let's say that they have AD pathology, but they have significant vascular disease. We might have a longer discussion, and I would caution them about moving forward. Patients with non-MRI compatible pacemaker would not be a candidate. We also talk about the commitment it would take to follow these protocols, being available every 2 weeks for infusion, and sticking with the MRI protocols. We also have recently had discussions about lifestyle and behavioral issues that might impact their ability to follow through with treatment. We tell them that they may not be an optimal candidate for treatment until these things have been addressed.
I also think the appropriate candidates for LEQEMBI have a reliable caregiver or someone in their life who can speak up if the patient has a complication and if they're unable or unwilling to report it.
I agree about family support. We have allowed patients with minimal family support to receive medication, and we have found that it can be very challenging when they don't have individuals in their lives that are really tracking their progress, watching them, monitoring them, helping them get to infusion treatments. It becomes a challenge identifying what has been going on. Have they been following protocol? How are they doing on their day-to-day?
We also have to consider other things, such as concomitant medications. We are particularly cautious when patients are on certain blood-thinning agents. They should have ApoE genetic testing so that we can better understand their individualized ARIA risk. Also, I agree with your earlier comments about patients with evidence of cerebrovascular disease on their MRI. What else do you look for in your ideal patient, Dr. Moon?
When we look at patients, particularly from a vascular standpoint, we also look for those who have less disease. We feel more comfortable treating those patients. An optimal patient, to me, is someone who comes in and identifies their problem at an early stage. They have mild deficits on memory testing, very mild atrophy on MRI, but they have confirmatory tests that suggest AD pathology. After we have completed the workup, we want to start thinking about treatment. I start off by saying, we now have concern that your memory problem may be progressive and that you may be at the earliest stages of Alzheimer's disease. As this disease progresses, we may encounter more problems with memory and day-to-day function. Then I start talking about what we can do. When we think about other difficult or challenging disease states, we give a diagnosis and then the immediate discussion is, what can we do? How can we fight this? That's where we pivot. I say, we have made some advancements over the last several years in this field, and we have an approved therapy available that may be appropriate for you to consider. We talk about how it's an infusion therapy that they would be given every 2 weeks, and that the purpose of the medication is to remove toxic soluble amyloid aggregates and plaques that are believed to cause the disease. I do caution them that LEQEMBI is not a cure, that it will not bring back their memory, but I tell them this may allow you or your loved ones to take steps to slow down how fast the disease is progressing. We talk about day-to-day functioning. Then we talk about side effects, and we go into detail about what they may entail. We talk about the future. They may ask, is this forever? I tell them this is a continuous disease process that may require continued treatment, and that we can use our clinical judgment and make a decision together about when it's time to stop. We as clinicians know that even after amyloid plaque is removed, the disease doesn't stop. Neurotoxic, soluble amyloid aggregates like protofibrils continue to form.
I often start with something like, we know that Alzheimer's is a progressive disease and this treatment slows down the disease progression. I've got a dry erase board and I sometimes use that to replicate the graph from the phase 3 study where you see the split in disease progression as time goes on between the treated and untreated people. And again, I say, it doesn't make you better, but it slowed the decline compared to people who are otherwise untreated. Most people seem to get that.
I tell them if we are thinking about potential therapy moving forward, and by that point, that's where their mind is, we would like to do this genetic test. And this genetic test will help us assess whether or not they are at higher risk of potential side effects.
Yeah, I take a similar approach. I explain that ApoE4 represents a common risk factor gene for AD. However, I recommend doing this test for a different reason, which, as you say, is to help to predict how likely it is they will develop a serious side effect from LEQEMBI.
Usually, that patient is in there with an adult child or some other family members, and then the conversation switches to them. I say, if these markers come back, that will imply a risk to you, the family member. Then we have a deeper conversation of what that may mean. If you will have one copy of ApoE4, this will increase your possible likelihood of developing Alzheimer's disease. If you have 2 copies, it will increase your likelihood even more. Then we ask them whether or not they want to know such information. Before we order it, we always talk to them first and say, please think about this before we make a decision on ordering the test. Patients have the right to decline the test, although most of them have done the test. But in my experience, patients end up doing it as they want to be proactive in this process.
We're doing this test to speak to the likelihood of development of ARIA, and that's why it's important. For example, say someone on LEQEMBI is ApoE44, and they call reporting a new but mild and otherwise uncomplicated headache. I might investigate that symptom more aggressively than someone who's not ApoE44, as I've got to be more concerned and have a higher index of suspicion for ARIA in the ApoE44 patient. Ultimately, I suspect I'll more readily order additional MRI studies in my patients who are ApoE44 than those who are not. This may be an oversimplification for physicians, but I explain ARIA to my patients by saying that this drug can cause bleeding and swelling in the brain. I think you have to communicate the gravity of the safety considerations up front because the patients and their families deserve to know about the possibility of severe and potentially life-threatening complications. I start with this language, but then I move on to say that ARIA is usually asymptomatic. Using ApoE genetic testing, we can predict how likely it is to happen. I think we all have our own ways to translate complex medical pathophysiology to patients, and explain the hypothesized pathophysiology of ARIA is no exception. I explained that the amyloid protein builds up in the brain tissue and the blood vessels. You can imagine blood vessels in the brain are like pipes, and amyloid is like rust on a pipe. If you scrape off that rust from the wall of the pipe, that pipe can get leaky, and it can release blood or fluid into the surrounding brain.
Generally, at this point, patients are fairly motivated, and their families are motivated, and they are there to keep each other in line. I try to incorporate everyone, so maybe they have an adult child in town, and maybe 2 out of town. I'll have them call in so that everyone who needs to be in that room the first couple of visits hears the same discussion. That way they can assert their accountability to themselves. Who's going to be monitoring this day to day? Well, they all are. This helps establish the team concept in supporting that family member. They know what awaits. Initially, we talk about infusion reactions, particularly with the first infusion. We talk about that it usually occurs early on, and that about 1 in 4 people will experience this. Symptoms can include fever and flu-like symptoms, like chills, generalized aches, feeling shaky, joint pain, and other symptoms such as nausea, vomiting, hypotension, hypertension, and oxygen desaturation. We relay that generally speaking, after the first infusion reactions are less common. We don't say that they won't have this side effect after the first infusion. We just say that many patients experience that side effect only with that first infusion. We set clear expectations about that.
Infusions can cause anything from a little bit of feeling flushed or uncomfortable to very severe allergic reactions. Per the label, severe infusion-related reactions are uncommon. We can manage most infusion reactions by giving antihistamines, acetaminophen, non-steroidal anti-inflammatory drugs, or corticosteroids prior to future infusions. In my clinical treatment of my patients, I personally have my patients stay in the infusion center after treatment is completed to monitor for infusion reactions. After the first 2 treatments, they stay for 2 hours after the infusion is done, 1 hour after the 3rd and 4th treatment, and up to half an hour from the 5th treatment on to make sure they don't have any delayed reactions. You should use your own clinical judgment on how to monitor your own patients. In terms of MRI monitoring, most patients are prepared for that at this point in the process. They've usually already had MRI to begin with because, in my practice, we do the baseline MRI before a clinical visit too, so we've confirmed they can do MRI. If they are a potential LEQEMBI candidate, at the 3rd visit we talk about the need for additional MRIs in the first 6 months of treatment.
We have a wonderful team who understands this process. We talk about it as a group, and we talk about any changes as a group. This involves nurse practitioners who along the way help manage these patients, our medical assistants who are aware where to send these patients for testing and to follow them up, our radiologists who have been trained to look for ARIA, and our infusion colleagues who understand that they are a checkpoint if that patient needs to stop, pause, and get that MRI before we continue infusions. They are also there to tell us if the patient has not shown up for the last visit, although we have not had that. That has been discussed with all of our infusion centers. We are referring to centers that are closely aligned with us, and there are 3 different infusion centers that we have used. So it's a process that takes a little time. It takes a little time to develop those people in the community that you'll trust with your patients. As LEQEMBI becomes more broadly used, and as radiologists in different sites and infusion centers at different places get more familiar with this will become more standardized in the community.
I have a nurse practitioner and a physician's assistant who coordinate the nuts and bolts of the infusion process. While not every practice has the luxury of an advanced practice provider, I find it's more appropriate and cost-effective for them to do phone check-ins, ensure patients are on track with their infusions, and interact with the infusion centers than it is for me to do all of this. If I had an RN, I probably would turn over much of that to them. However, especially given this is a new process, I think I would still feel more comfortable knowing that someone with a higher level of training was doing all that I just described.
In working with outside infusion centers, it's key that you bring them into the conversation early. You have to sit down and talk to their leadership saying, this is what we're trying to do. This is what we need from you, and this is the expectation of our protocols. They are rapid to learn, and they are rapid to accommodate. I think you'll find a positive experience within that infusion community. This is very challenging. One of our patients comes from far western Kansas, so they have very limited access to tests and specialists. They make a 3 to 4 hour drive just to see us and to get infusions performed. We talked to them about maybe working with a local infusion center so that they can get that locally. But because they were one of our earliest patients, they wanted to just come in to Denver directly. Eventually, we're going to try to transition these individuals to a local center. We would need to work with them and train them on how to see these patients. Hopefully, this can be made more accessible to individuals in rural Kansas or Wyoming, or on the western slope of Colorado, where maybe they don't have as much access to therapy. Telemedicine has allowed us to facilitate some of those follow-ups more easily, but we do need sites regionally to supply and support these patients.
I agree that it's hard. I think you've got to start really emphasizing in visits 2 and 3 what this looks like, especially if they're living alone and they're planning on driving an hour or 2 to get to an infusion center. For the rural people, it's that much more important to ensure there's a reliable caregiver who can actively assist with getting patients safely to their infusions. Unfortunately, some people in very rural areas may not be able to receive treatment because of the distances required to receive infusions.
LEQEMBI can cause ARIA-E and ARIA-H. ARIA-E can be observed on MRI as brain edema or sulcal effusions, and ARIA-H as microhemorrhage and superficial siderosis. I don't think that all neurologists know that ARIA can occur spontaneously in patients with Alzheimer's disease. We do see microhemorrhages and edema in untreated individuals. Even the placebo patients may have this. The reason we aren't familiar with this is because we don't, in clinical practice, follow these patients up with subsequent MRIs.
I'd like general neurologists to better understand the concepts of ARIA-E and ARIA-H. It helps to tell them that you see ARIA-E the best on FLAIR MRI. You see ARIA-H based on whatever blood-sensitive sequences your MRI centers use, usually GRE, T2 star, or SWI. We should really be emphasizing that those are the minimum sequences they should review in their treated patients, and I would encourage them to look at all the MRI images themselves. Also, when you can, send patients to the same MRI time after time because there are often technical differences between MRI machines, especially when they are with different organizations. Make sure you're communicating to the reading neuroradiologist that you're looking for ARIA.
We had identified our radiologists early on, and we had them take a little bit of a deep dive in ARIA. This is something that we probably have to do on a regular basis to get new clinicians on board. Then we talked to their leadership about what we're looking for, and what we need from them in terms of how they communicate with us. I have a cell phone relationship with a lot of our radiologists, so they simply call me when they have these findings and have me take an immediate look. But we have also worked out how to phrase it in our order sheet when ordering the MRI so that they know what we are asking them to look for.
I would also encourage neurologists to communicate with the radiologists. They can't just say there are some microhemorrhages or a few or whatever. They need to actually quantify them. You at least need to say, give me a number, or how many are new, because you know that's what characterizes mild, moderate, and severe ARIA, and that can have very real implications for treatment. It helps to have a neuroradiologist who has decided that they're going to be the champion or advocate for their group on the subject of ARIA. The neuroradiologist will communicate the important concepts not only to their fellow neuroradiologists, but also to the staff.
Right. The staff needs to understand that this patient is on medication and that this is what we're looking for. How does the technician receive that order? Then, how do they relay it to the radiologist so that the radiologist understands that this patient is on LEQEMBI and we are looking for ARIA? If the neuroradiologist is new to ARIA monitoring, we typically have the radiology group help with the initial training. In terms of infusion, what's critical is working not only with their leadership, but maybe a key individual who is more familiar with the protocol and the therapeutic options, and what the potential experience may be with our patients. In clinical settings, we are gaining confidence as we encounter an abnormality on the MRI. We are all learning this process as we're doing it. A very important message to relay to the general neurologist is that most of the time, patients don't even know what's happening to them because they're asymptomatic, and that we're catching this on MRI. That does give all of us a level of comfort, even though we do see these abnormalities, sometimes on imaging. That will allow us to kind of think through the process and make appropriate decisions in terms of how to move the patient clinically forward. Then our patients have a follow-up scheduled so that we can have a conversation in person. We show them the abnormality. We say that this can be seen in normal, healthy individuals, but because they are on medication, there are considerations. Then we decide together on whether we're going to continue. We show them the general recommendations from the LEQEMBI prescribing information. If they are safe to continue from those general recommendations, we say we think you can continue, and we will monitor you closely and reassess in another month. It's been exciting to see new advancements. Sometimes it's week to week, and we're evolving our own protocols internally.
I agree. The more we can connect and learn from each other, the more our patients will benefit. Let's now review the important safety information for LEQEMBI.
Important safety information. Indication. LEQEMBI is indicated for the treatment of Alzheimer's disease, AD. Treatment with LEQEMBI should be initiated in patients with mild cognitive impairment, MCI, or mild dementia stage of disease, the population in which treatment was initiated in clinical trials. Important safety information. Warning: amyloid-related imaging abnormalities, ARIA. Monoclonal antibodies directed against aggregated forms of beta amyloid, including LEQEMBI, can cause ARIA, characterized as ARIA with edema, ARIA-E, and ARIA with hemosiderin deposition, ARIA-H. Incidence and timing of ARIA vary among treatments. ARIA usually occurs early in treatment and is usually asymptomatic, although serious and life-threatening events, including seizure and status epilepticus, can occur. ARIA can be fatal. Serious intracerebral hemorrhages, ICH, greater than 1 centimeter, some of which have been fatal, have been observed with this class of medications. Because ARIA-E can cause focal neurologic deficits that can mimic an ischemic stroke, consider whether such symptoms could be due to ARIA-E before giving thrombolytic therapy to a patient being treated with LEQEMBI. Apolipoprotein E4, ApoE4 homozygotes. Patients who are ApoE4 homozygotes, approximately 15% of patients with AD treated with this class of medications, have a higher incidence of ARIA, including symptomatic, serious, and severe radiographic ARIA compared to heterozygotes and non-carriers. Testing for ApoE4 status should be performed prior to initiation of treatment to inform the risk of developing ARIA. Prior to testing, prescribers should discuss with patients the risk of ARIA across genotypes and the implications of genetic testing results. Prescribers should inform patients that if genotype testing is not performed, they can still be treated with LEQEMBI. However, it cannot be determined if they are ApoE4 homozygotes and at higher risk for ARIA. Consider the benefit of LEQEMBI for the treatment of AD and the potential risk of serious ARIA events when deciding to initiate treatment with LEQEMBI. Contraindication. Contraindicated in patients with serious hypersensitivity to lecanemab-irmb or to any of the excipients. Reactions have included angioedema and anaphylaxis. Warnings and precautions. Amyloid-related imaging abnormalities. Medications in this class, including LEQEMBI, can cause ARIA-E, which can be observed on MRI as brain edema or sulcal effusions, and ARIA-H, which includes microhemorrhage and superficial siderosis. ARIA can occur spontaneously in patients with AD, particularly in patients with MRI findings suggestive of cerebral amyloid angiopathy, CAA, such as pre-treatment microhemorrhage or superficial siderosis. ARIA-H generally occurs with ARIA-E. Reported ARIA symptoms may include headache, confusion, visual changes, dizziness, nausea, and gait difficulty. Focal neurologic deficits may also occur. Symptoms usually resolve over time. Incidence of ARIA. Symptomatic ARIA occurred in 3% and serious ARIA symptoms in 0.7% with LEQEMBI. Clinical ARIA symptoms resolved in 79% of patients during the period of observation. ARIA, including asymptomatic radiographic events, was observed LEQEMBI 21%, placebo 9%. ARIA-E was observed LEQEMBI 13%, placebo 2%. ARIA-H was observed LEQEMBI 17%, placebo 9%. No increase in isolated ARIA-H was observed for LEQEMBI versus placebo. Incidence of ICH. ICH greater than 1 centimeter in diameter was reported in 0.7% with LEQEMBI versus 0.1% with placebo. Fatal events of ICH in patients taking LEQEMBI have been observed. Risk factors of ARIA and ICH. ApoE4 carrier status. Of the patients taking LEQEMBI, 16% were ApoE4 homozygotes, 53% were heterozygotes, and 31% were non-carriers. With LEQEMBI, ARIA was higher in ApoE4 homozygotes, LEQEMBI 45%, placebo 22%, than in heterozygotes, LEQEMBI 19%, placebo 9%, and non-carriers, LEQEMBI 13%, placebo 4%. Symptomatic ARIA-E occurred in 9% of ApoE4 homozygotes versus 2% of heterozygotes and 1% of non-carriers. Serious ARIA events occurred in 3% of ApoE4 homozygotes and in approximately 1% of heterozygotes and non-carriers. The recommendations on management of ARIA do not differ between ApoE4 carriers and non-carriers. Radiographic findings of CAA. Neuroimaging findings that may indicate CAA include evidence of prior ICH, cerebral microhemorrhage, and cortical superficial siderosis. CAA has an increased risk for ICH. The presence of an ApoE4 allele is also associated with CAA. The baseline presence of at least 2 microhemorrhages or the presence of at least 1 area of superficial siderosis on MRI, which may be suggestive of CAA, have been identified as risk factors for ARIA. Patients were excluded from Clarity AD for the presence of greater than 4 microhemorrhages and additional findings suggestive of CAA, prior cerebral hemorrhage greater than 1 centimeter in greatest diameter, superficial siderosis, vasogenic edema, or other lesions, aneurysm, vascular malformation that could potentially increase the risk of ICH. Concomitant antithrombotic or thrombolytic medication. In Clarity AD, baseline use of antithrombotic medication, aspirin, other antiplatelets, or anticoagulants was allowed if the patient was on a stable dose. Most exposures were to aspirin. Antithrombotic medications did not increase the risk of ARIA with LEQEMBI. The incidence of ICH, 0.9% in patients taking LEQEMBI with a concomitant antithrombotic medication versus 0.6% with no antithrombotic and 2.5% in patients taking LEQEMBI with an anticoagulant alone or with antiplatelet medications such as aspirin versus none in patients receiving placebo. Fatal cerebral hemorrhage has occurred in one patient taking an anti-amyloid monoclonal antibody in the setting of focal neurologic symptoms of ARIA and the use of a thrombolytic agent. Additional caution should be exercised when considering the administration of antithrombotics or a thrombolytic agent, for example tissue plasminogen activator, to a patient already being treated with LEQEMBI. Because ARIA-E can cause focal neurologic deficits that can mimic an ischemic stroke, treating clinicians should consider whether such symptoms could be due to ARIA-E before giving thrombolytic therapy in a patient being treated with LEQEMBI. Caution should be exercised when considering the use of LEQEMBI in patients with factors that indicate an increased risk for ICH and, in particular, patients who need to be on anticoagulant therapy or patients with findings on MRI that are suggestive of CAA. Radiographic severity with LEQEMBI. Most ARIA-E radiographic events occurred within the first 7 doses, although ARIA can occur at any time, and patients can have greater than 1 episode. Maximum radiographic severity of ARIA-E with LEQEMBI was mild in 4%, moderate in 7%, and severe in 1% of patients. Resolution on MRI occurred in 52% of ARIA-E patients by 12 weeks, 81% by 17 weeks, and 100% overall after detection. Maximum radiographic severity of ARIA-H microhemorrhage with LEQEMBI was mild in 9%, moderate in 2%, and severe in 3% of patients. Superficial siderosis was mild in 4%, moderate in 1%, and severe in 0.4% of patients. With LEQEMBI, the rate of severe radiographic ARIA-E was highest in ApoE4 homozygotes, 5%, versus heterozygotes, 0.4%, or non-carriers, 0%. With LEQEMBI, the rate of severe radiographic ARIA-H was highest in ApoE4 homozygotes, 13.5%, versus heterozygotes, 2.1%, or non-carriers, 1.1%. Monitoring and dose management guidelines. Baseline brain MRI and periodic monitoring with MRI are recommended. Enhanced clinical vigilance for ARIA is recommended during the first 14 weeks of treatment. Depending on ARIA-E and ARIA-H clinical symptoms and radiographic severity, use clinical judgment when considering whether to continue dosing or to temporarily or permanently discontinue LEQEMBI. If a patient experiences ARIA symptoms, clinical evaluation should be performed, including MRI if indicated. If ARIA is observed on MRI, careful clinical evaluation should be performed prior to continuing treatment. Hypersensitivity reactions. Hypersensitivity reactions, including angioedema, bronchospasm, and anaphylaxis, have occurred with LEQEMBI. Promptly discontinue the infusion upon the first observation of any signs or symptoms consistent with a hypersensitivity reaction and initiate appropriate therapy. Infusion-related reactions, IRRs. IRRs were observed. LEQEMBI 26%, placebo 7%, and most cases with LEQEMBI 75% occurred with the first infusion. IRRs were mostly mild 69% or moderate 28%. Symptoms included fever and flu-like symptoms, chills, generalized aches, feeling shaky, and joint pain, nausea, vomiting, hypotension, hypertension, and oxygen desaturation. IRRs can occur during or after the completion of infusion. In the event of an IRR during the infusion rate may be reduced or discontinued and appropriate therapy initiated as clinically indicated. Consider prophylactic treatment prior to future infusions with antihistamines, acetaminophen, non-steroidal anti-inflammatory drugs, or corticosteroids. Adverse reactions. The most common adverse reactions reported in greater than or equal to 5% with LEQEMBI infusion every 2 weeks and greater than or equal to 2% higher than placebo were IRRs, LEQEMBI 26%, placebo 7%, ARIA-H, LEQEMBI 14%, placebo 8%, ARIA-E, LEQEMBI 13%, placebo 2%, headache, LEQEMBI 11%, placebo 8%, superficial siderosis of central nervous system, LEQEMBI 6%, placebo 3%, rash, LEQEMBI 6%, placebo 4%, and nausea, vomiting, LEQEMBI 6%, placebo 4%. Safety profile of LEQEMBI iClick for maintenance treatment was similar to LEQEMBI infusion. Patients who received LEQEMBI iClick experienced localized and systemic, less frequent, injection-related reactions, mild to moderate in severity. LEQEMBI, lecanemab-irmb, is available intravenous infusion, 100 mg per milliliter, subcutaneous injection, 200 mg per milliliter.
Thank you for watching. I hope you feel more confident that you can take these steps to identify, treat, support, and counsel appropriate patients and their families.
It's our responsibility to guide them through the journey with LEQEMBI. For more information about LEQEMBI, visit www.leqembihcp.com.